Blood and clotting. Various blood disorders can be very common, like iron deficiency anemia, to rare, hereditary spherocytosis. And these various disorders encompass red blood cell production and function, platelet disorders, and disorders of bleeding and clotting. Atherosclerosis and atrial fib are the most prevalent in the United States. The most common cause of death is MI, often due to a blood clot formed secondary to coronary atherosclerosis, and AFib promotes clot formation, which will significantly increase the risk of stroke. Risk reduction in patients diagnosed with acute coronary syndrome will include treatment with antiplatelet agents like aspirin or clopidogrel. Patients that are at risk for embolism due to AFib or venous thrombosis are managed with anticoagulants like warfarin. Anemia is a health disorder that is common throughout the world. These are common blood disorders looking at anemias or genetic traits and bleeding or clotting disorders. Without an adequate blood supply, tissue will soon become ischemic and die. Red blood cells deliver oxygen to tissues and remove carbon dioxide. It also transports white blood cells, platelets, and proteins necessary for coagulation, complement, and kinin systems to the sites of injury and pathogen invasion. Cells also regulate body temperature, assist to maintain acid-base imbalance, transport nutrients, and discard various wastes, and they are carriers of hormones to target tissues. Blood is routinely composed of plasma and formed elements. The plasma is approximately 55% of the whole blood, and the remaining 45% is formed elements. Blood volume will vary with the size of the individual, and blood encompasses red cells, white cells, and platelets. The purpose of red blood cells is to travel between the lungs and the tissues that carry oxygen, where it transfers carbon dioxide for oxygen and disposes of carbon dioxide from the lungs. Red cells, they do not have any nuclei, organelles, or ribosomes. They cannot undergo mitotic division or do cell repair. This limits their lifespan to approximately 3 months. They need to have a specific size and shape that allow them to travel through small capillaries. Red blood cell size is estimated as mean cell volume. Differential diagnosis of many red blood cell disorders include the identification of macrocytosis, which is an increase in the mean cell volume, microcytosis, or normal cell volume, which should be between 80 to 100 fluid liters. Various conditions like sickle cell disease, hemolysis, thalassemia, these are associated with a greater than normal variability of the red blood cell size. Abnormally high white cell distribution width is also named anocytosis. This indicates a varying size of the red blood cells that is observed. The color of a cell is routinely normochromic or it can also be pale, which is hypochromic. The only source of red blood cell formation is the stem cell in the bone marrow. There are two types of bone marrow, that's red and yellow. Red is capable of cell production and yellow is high in fat content and will gradually replace the red bone marrow during childhood years. So red bone marrow is the source of the red cells, white cells, and the platelets. The stages of bone marrow red cell development end at the reticulocyte. This is the point the cell leaves the bone marrow and enters the circulation. Hemoglobin production begins during the basophilic erythroblast stage, and it will continue through the reticulocyte phase, as long as hemoglobin RNA is available and present. Each hemoglobin molecule is composed of 2 pairs of polypeptide chains and 4 heme or iron complexes. Mutations in the genes that code for the alpha or beta chains can produce hemoglobinopathies. Okay. Sickle cell disease and sickle cell trait are due to single base or missense mutations in the beta globulin gene. Hemoglobulin S is the primary hemoglobin that is produced in the homozygotes. These individuals are referred to as having sickle cell disease. Heterozygotes are referred to having sickle cell traits. The elongated heme S polymers will align and deform the red blood cell into the sickle shape. This is facilitated under conditions of dehydration, which concentrates the hemoglobin within the red cell cytoplasm. Hypoxia and acidosis will further favor sickling, and the misshaped cells will block small vessels and produce severe pain that is secondary due to tissue ischemia. This is a diagram of hemoglobin A and hemoglobin S. The beta chain of hemoglobin S has a valine substituted for glutamate at position 6. This forms a hydrophobic sticky spot on the outside of the molecule. The deoxygenation exposes a complement hydrophobe site on the alpha chain where the 2 hemoglobin molecules can stick together by hydrophobic attraction. This process will repeat until long polymers of hemoglobin S molecules are produced and deform the red blood cell into the elongated sickle shape. Dehydration further perpetuates the hemoglobin S concentration. Thalassemia is a term for a group of genetic disorders that result in abnormal production of either alpha or beta hemoglobin chains. Beta thalassemias are associated with hypochromic mitocytic anemia due to the reduction in red blood cell hemoglobin concentration. Anemia is defined as decreased red blood cell mass or hemoglobin content of the blood. Hemostatic compensation for anemia depends on the rate and duration of blood loss. Hemorrhage induces rapid loss of red blood cells and plasma. with an abrupt decrease in hemoglobin, hematocrit, and blood volume. These changes will elicit dramatic hypotension with compensatory tachycardia and tachypnea. Patients will present with pallor of the skin and mucous membranes, fatigue, exercise intolerance, and in severe cases, they might complain of syncope. Iron is necessary for hemoglobin production. Total body iron is approximately 3 to 4 grams, with at least half contained in hemoglobin molecules. Iron is poorly soluble in plasma, so it is transported in the blood by binding with the protein transferrin. The transferrin ion complex carries iron to the bone marrow, where it binds with transferrin receptors on erythroblasts. Transferrin bound to iron is referred to as saturated transferrin, and the percentage of transferrin saturation varies from 20 to 50% in healthy individuals. Iron used for hemoglobin synthesis comes from two sources. 5% is obtained from gastrointestinal absorption of dietary iron, which takes place in the duodenum, and 95% is recycled from the breakdown of aging red blood cells in the spleen. Iron is stored intracellularly with the greatest storage in the liver and macrophages. Iron can move from ferritin-bound to free inside cells. Some ferritin is present in plasma, and the blood ferritin level is measured in the differential diagnosis of anemia. Iron balance is disrupted by an inadequate intake or absorption, or by excessive demands. In older adults, GI loss associated with malignancy may cause severe excessive iron demand. GI malabsorption, like Crohn's disease, celiac disease, or those secondary to weight loss surgery, often require supplemental to maintain erythropoiesis. In all cases, if dietary supply and body stores in the liver and other tissues are not adequate, iron deficiency anemia will occur. Splenic macrophages break down aging red blood cells, releasing 95% of the iron needed for red cell synthesis. The iron is released from the spleen and then binds to the plasma carrier protein, transferrin, for transport to the bone marrow. The clinical features of iron deficiency anemia depend on the degree of anemia. Some individuals may be asymptomatic or may have mild to severe signs and symptoms. These may include fatigue, generalized weakness, dyspnea on exertion, orthostatic lightheadedness, restless leg syndrome, and tachycardia. Anemia of long duration can be associated with pica and the appearance of a smooth tongue and brittle nails. Lab studies in iron deficiency anemia will reveal decreased red blood cell count, hemoglobin, and hematocrit, decreased serum iron and ferritin, increased total iron binding capacity and transferrin levels, low transferrin saturation, and microcytic hypochromic red blood cells. The bone marrow biopsy is the gold standard to confirm iron deficiency anemia. The rapid proliferation of bone marrow RBC precursors requires a sufficient supply of vitamin B12 and folate. The dietary sources of vitamin B12 is animal products, including meats, eggs, dairy, and deficiency can be seen in people that are on vegetarian or vegan diets. Pernicious anemia is an autoimmune disorder with destruction of gastric parietal cells. The resulting lack of intrinsic factor prevents vitamin B12 absorption. Individuals that have H. pylori infection, maladaptive conditions, bariatric surgery can all be affected by poor vitamin B12 absorption. Anemia of chronic inflammation is an umbrella term for a subset of anemias that occur secondary to infections, malignancy, or connective tissues that lasts for 1 month or longer. Infections that can result in ACI would include bacterial endocarditis, osteomyelitis, pyelonephritis, or even late stages of HIV. Anemia of chronic kidney disease is extremely common in patients with renal failure. The primary mechanism is the loss of erythropoietin that is produced by the failing kidneys. In clinical practice, this has been managed with exogenous erythropoietin. Hemolytic anemia results when RBCs are destroyed before their normal lifespan of 100 to 120 days. If erythropoiesis cannot keep up with the destruction of RBCs, anemia will result. Hemolysis resulting from intrinsic RBC defects is often genetic and occurs in patients with hemoglobin abnormality. Intravascular hemolysis occurs within the blood vessels, and extravascular hemolysis occurs within the spleen system. When diagnosing for hemolytic anemia, the bilirubin is going to be greatly increased. Red cells will be decreased. The breakdown of RBCs releases hemoglobin. The protein chains of hemoglobin are broken down to their constituent amino acids, and the iron atoms travel in circulation bound to transferrin to return to the bone marrow for synthesis of new hemoglobin. The heme component of hemoglobin is metabolized first to biliverdin, then bilirubin. Unconjugated bilirubin is hydrophobic and it binds to plasma albumin for transport to the liver. The liver cells take up bilirubin and conjugate it, increasing its water solubility and excreting much of this conjugated bilirubin into bile. GCPD is a metabolic enzyme that catalyzes the first reaction in the pentose phosphate pathway, a route of glucose metabolism that generates reduced nicotinamide adenine dinucleotide phosphate. The G6PD gene is located on the X chromosome, meaning that it has a X-linked inheritance pattern and that males are more severely affected. Autoimmune hemolytic anemia is an uncommon condition that is characterized by the body's production of anti-RBC autoantibodies. Hemostasis, or blood clotting, is a vital defense system contributing to hemostasis by preventing hemorrhage or reducing blood loss when there is a break or an injury in the vasculature. Hemostasis is a tightly regulated cascade of responses to an injury. This cascade will lead to a platelet plug formation, followed by the production of a stable clot. This is a very rapid and localized process. Platelets are non-nucleated fragments with a lifespan of 7 to 10 days. The platelets circulate between the vasculature and the spleen. The production of platelets is stimulated by thrombopoietin, which is a protein synthesized by the liver and the kidneys. Clots form at sites of vascular damage when the endothelial cell layer is disrupted and the ECM is exposed. The formation of the primary clot depends on the platelet adherence to the ECM. As platelets are undergoing activation and adhesion to the region of vascular damage, tissue factor and factor 7A begin to cleave factor X, which converts prothrombin to thrombin. The thrombin contributes to platelet activation and activating other clotlet factors and breaking down fibrinogen into the fibrin strands, and these strands begin cross-linking among the aggregated platelets. The platelet surfaces are the site of deposition and activity of the clotting cascade proteins of the intrinsic and common pathways. This provides a local positive feedback to accelerate fibrin deposition and clot formation. The coagulation cascade takes place on the membrane of activated platelets, where zymogens and cofactors are stabilized on the phospholipid surface by calcium ion binding. Proteases are stabilized by tissue factor, cofactor 8 and cofactor 5. The tissue damage initiates clotting by the extrinsic pathway. Factor 7A initiates the common pathway, generating factor XA, which is stabilized by factor 5A and functions as prothrombin convertase, cleaving prothrombin to release active thrombin. Factor 7A also activates factor 9, which adding to the intrinsic pathway reinforcement of the early extrinsic pathway activity. Two products of arachidonic acid metabolism are prostacyclin and thromboxane A2. These are significant in the balance of anticoagulant and procoagulant forces in healthy and damaged vessels. This is a summary of the platelets in hemostasis. The coagulation cascade occurs on the surface of platelets as a coordinated step-by-step activation of multiple circulating plasma protein factors, leading to the deposit of insoluble fibrin on the platelet plug and transforming it into a stable clot. As the coagulation cascade accelerates, thrombin provides positive feedback by activating the cofactors number 5 and number 8, as well as factor 11 of the intrinsic pathway, which further accelerates the deposit of fibrin. The asterisks here indicate the clotting factors 2, 7, 9, and 10 that are subjected to carboxylation during synthesis in the liver. In the prothrombin laboratory test, tissue factor is added to a blood sample and time to clot formation is measured. This test primarily evaluates the extrinsic pathway and normally takes 10 to 14 seconds. In addition to assessing the extrinsic pathway, the PT and the related INR are also used to assess the degree of anticoagulation in patients that take warfarin. In the PTT lab test, a source of negative charges is added to a blood sample and time to clot formation is measured. This test primarily evaluates the intrinsic and common pathways and normally takes 32 to 45 seconds. The PTT can be prolonged in disease states of hemophilia, DIC, and liver failure, as well as people that take the drug heparin. Clots that dislodge from their formation sites are called emboli and travel through the circulation to organs where they can lodge and cause ischemia and infarction. Under routine healthy conditions, endothelial cells have the following properties that both inhibit platelet adhesion and activation. The endothelial cells express nitric oxide synthase and release nitric oxide, which is a potent inhibitor of platelet activation and aggregation. The endothelial cells also metabolize arachidonic acid to prostacyclin, a potent local inhibitor of platelet activation and aggregation. Healthy endothelial cells in an intact blood vessel have several anticoagulant properties. They secrete prostacyclin and nitric acid into the blood vessel and to the underlying smooth muscle layer. Both of these inhibit platelet activation and promote vasodilation, thus maintaining a steady stream of blood flow that reduces blood pooling and intrinsic pathway activation. The plasma system is responsible for breaking down clots when healing has occurred. TPA and UPA cleave the protein plasminogen into the circulation and bound in the clot to release plasmin. Plasmin is an enzyme that breaks down cross-linked fibrin within the clot, dissolving the clot and releasing fibrin breakdown clot products such as D-dimer. The plasmin system is regulated by the plasma protein alpha-2 antiplasmin, which blocks the action of the circulating plasmin and plasminogen activator inhibitor, which is produced by endothelial cell and other types of cells. The inhibition of clotting is critical once a clot has formed to prevent extension of this process to adjacent healthy regions of vasculature. There are two main systems that are in place to inhibit either the coagulation proteases. One is in yellow and the other are the cofactors in blue. The circulating mediator AT3 binds to the endothelial cell and inactivates the proteases. Protein C and protein S work together to cleave and inactivate the proteins 8 and 5, the required cofactors for factors 9 and factors 10. When acute clotting takes place, it needs to be modulated. This can be done surgically, as in a thrombectomy. It can be done by medicine with TPA. It can also be done with various other medications. Aspirin is something that is given to individuals as a daily regimen at 81 milligrams to help maintain their coagulability. Warfarin or Coumadin is another medication that is given often for people that are prone to be developers of clotting states. The AA sequences of factors 2, 7, 9, and 10 include an N-terminal region enriched in glutamate residues. The glutamate carboxyl group is normally depropionated and negatively charged at the physiological pH. The liver enzyme gamma carboxylase adds one more carboxyl group, which is the red oval at the top of the image, to these glutamates in a post-translational reaction. This reaction adds a negatively charged extension to the protein, facilitating binding to platelet surfaces by calcium once the precursor zymogen has been activated. The vitamin K serves as a cofactor, transitioning from the reduced to the oxidized state. The World Health Organization calculates that the top causes of death worldwide are ischemic heart disease and strokes. These disorders account for 15 million deaths annually, representing more than 1/4 of all deaths internationally. Endothelial injury can be a catalyst for intravascular clot formation, particularly in the arterial circulation. Venous stasis and other states of low blood flow promoting pooling of the blood, prolonged contraction with endothelium that may reduce some of its anti-clotting properties, and activation of the intrinsic pathway. Venous thromboembolism can break off from their formation site and travel through the right side of the heart into the pulmonary vasculature to cause a pulmonary embolism or multiple pulmonary emboli. Arterial thrombi often form at the sites of atherosclerotic plaque. Endothelial cells are diseased in the vicinity of the plaque, losing their normal antithrombotic properties and becoming sites of platelet aggregation and clot formation. In a catastrophic plaque rupture situation, the cap of the plaque fissures, exposing large amounts of tissue factor and other procoagulant structures. This can quickly lead to a massive thrombus that completely occludes the vessel and causes an MI or a stroke. Venous thrombi, often formed in areas of blood stasis, such as the deep veins of the legs. Circulating tissue factors may accumulate here, along with surface activation of intrinsic pathway proteins to produce clots. These clots may easily break off and travel through the right side of the heart to the lungs and then form the pulmonary emboli. Factor V Leiden results from an autosomal dominant mutation of the human F5 gene with incomplete penetrance. VFL mostly affects ethnic Caucasian Europeans with an estimated 3.2% to 6% prevalence in the United States. It is produced by a single base missense mutation in which guanine is replaced by adenine, resulting in an amino acid substitution of glutamine for arginine. Healthy young adults with an unexplained DVT or PE should be screened for VFL. Antiphospholipid syndrome is an autoimmune condition that results in increased clotting. This can occur secondary to an autoimmune diseases, most commonly systemic lupus. These are some of the hypocoagulable states that cause bleeding disorders. Dysfunction of hemostasis can produce signs and symptoms of excess bleeding, ranging from superficial petechiae to large ecchymosis, deep hematomas, and hemarthrosis, which is bleeding into the joints. These disorders may be present from birth as a result of genetic mutations or may be secondary to acquired autoimmune-mediated disorders. Excess bleeding can result from abnormalities of platelets, clotting factors, or both. Thrombocytopenia is classified as a blood platelet level that is lower than the normal of 150,000 to 450,000. Thrombocytopenia arises from three general mechanisms: decreased bone marrow production, increased sequestration, or increased destruction. Increased platelet destruction due to immune mechanisms can produce the greatest degree of thrombocytopenia, although these are rare. Increased platelet destruction stimulates the bone marrow to release young platelets that are larger than normal with reticular staining and greater clotting promoting activity. Acute onset immune thrombocytopenia purpura, or ITP, can occur spontaneously or after an infection and is more common in children. Chronic ITP is a classic autoimmune illness, and patients usually present because of skin manifestations like petechiae or purpura, or excessive bleeding in the gingival area, menageria, or epistaxis. Antibodies are produced against platelet membrane GPs or human leukocyte antigen proteins. Antibody binding targets the platelet for destruction by macrophages in the spleen and in the liver. Von Willebrand disease is the most common inherited bleeding disorder. It is a heterogeneous disease that occurs because of either a dysfunction or a lack of the VWF protein. VWF is a large multimeric glycoprotein that is coded by chromosome 12. VWF has two major roles: facilitating platelet aggregation at sites of vascular injury and helping to bind factor VIII to the platelet plug, which is a vital step in the production of thrombin, fibrin, and eventual clot formation. Hemophilia A, or factor VIII deficiency, is an X-linked recessive genetic disease. In hemophilia A mutation in the F8 gene results in a reduced amount of active factor VIII protein. This is either because of an improperly functioning protein or an overall decrease in its production. Factor VIII is produced in the liver and in the reticuloendothelial cells throughout the circulation. In families with a history of the disorder, factor VIII deficiency has an X-linked inheritance pattern in which all the sons of an affected father are unaffected and all the daughters are carriers. Patients with severe hemophilia A have a high risk of joint-related hemiarthrosis, spontaneous hematuria, mucous membrane bleeding, and hematoma formation. These are managed with a clotting factor replacement. These patients may have intracranial bleeding either spontaneously or as a result of a minor trauma, which is the leading cause of death for hemophiliacs. As the site of synthesis of most of the clotting factors, the liver has an integral role in the body's ability to maintain hemostasis. Patients with chronic cirrhotic liver disease are prone to cirrhosis-related coagulation dysfunction. Children are more likely than adults to present with certain blood and clotting disorders. Once the hemoglobin reaches values of approximately 10 milligrams per deciliter, erythropoietin is released from the kidneys, stimulating bone marrow with erythropoiesis. As erythropoiesis starts to increase the red cell count again, the hemoglobin level also will increase. Iron deficiency anemia is the most common red blood cell disorder of childhood and the most commonly incurred anemia in the pediatric population. At birth, both MCV and hemoglobin concentration are higher than normal adult levels. The mean cell value gradually decreases during childhood, with hemoglobin rapidly reaching a nadir within the first 6 months, then recovering by the teen years. Hyperbilirubinemia is a common and potentially life-threatening hematological condition in infancy, predominantly occurring within the neonatal period. Exceedingly high levels of bilirubin can have severe and potentially life-threatening effects, including hearing loss, intellectual disability, and encephalopathy. Children with sickle cell disease often have an enlarged spleen in infancy. RBC sickling causes obstruction and congestions in the sinusoids of the spleen. For von Willebrand's disease, the more severe the phenotype, the earlier the disease is likely to be diagnosed. Patients complain of gingival bleeding when brushing teeth, frequent and recurrent epistaxis, excessive bleeding with minor abrasions, or severe bruising from injuries involving relatively minor impact. Age-related changes in blood and clotting include changes in red cell count, hemoglobin, and hematocrit, changes in bone marrow, hypercoagulability, and effects related to medications commonly used in the older adult population. Three forms of anemia are prevalent in older adults. Anemias related to nutritional deficiency of iron, vitamin B12 or folic acid, anemia of chronic disease, and anemia of unknown origin. Anemia of inflammation is generally seen in older adults, particularly in patients with chronic illness, cancer, and rheumatoid disorders. Bone marrow in older adults changes in composition, containing more adipose tissue and fewer stem cells. In healthy older adults, clinical manifestations of changes in bone marrow and thymic mass are mild anemia and immune deficiency. Immune deficiency increases the risk of infection and neoplasms. Older adults are inclined to have a hypercoagulable state at baseline, thus increasing their risks of DVT, PE, cardiac emboli, and MI. Cardiovascular, cerebrovascular, and peripheral vascular diseases are often treated with drugs that affect clotting: aspirin, warfarin, direct oral anticoagulants, or platelet ADP receptor antagonists, like clopidogrel. This is a summary of blood and clotting.